Welcome today to the talk. My name is Dr. Emma Pollon-MacLeod. Today we're talking about cognitive health in menopause. The question, is it Alzheimer's or is it menopause? This is actually something that I hear quite frequently, and I'm really excited because this is this topic that I'm so passionate about. So thank you to the Memory Clinic, such a great resource that we have in Ottawa and in Gatineau that is bringing a lot of attention and driving the field of memory research forward. And we're really lucky to have them right here in the city. So thanks for putting this on. Okay. So I wanted to start with this slide because this is something that I hear all the time. Um, and this is a story that I see in clinic. I'm a practicing naturopathic doctor, and women coming in and, they've got tears in their eyes and they're talking about their symptoms, telling me that, they're forgetting names, they're not as sharp, they walk into a room, they're not sure why they're there. And, sometimes they're laughing about it, kind of like it's a little bit of a joke, like I'm losing my mind, but sometimes you can tell that they're actually concerned about the implications and what this means. Is it serious? Is it something that needs to be investigated? These are women, the other day I had a woman in my office, 51, bright, successful at the peak of her career. And now she's questioning her mind. She's questioning, is this something that's wrong with me? There's changes going on. I know they're going on, and they're suffering in silence because they don't really know where to turn. And again, we're not talking about it. Is it normal? Is it something actually worse? Is it something that needs to be investigated? So that's why we're here to talk about this today, to shine a light on the connection, the real connection between menopause and cognition and brain health. And it's not about causing fear. It's really a place to offer understanding, education, empowerment, support, and to provide with some actions and understanding of, what you can do today to help. So a little bit about me. I'm a naturopathic doctor. Like I said, I love speaking on women's health and hormones. I am a Menopause Society certified practitioner, meaning I have extra credentials in talking about perimenopause and menopause and hormone therapy that falls under the guidance of the Menopause Society of North America. My background is in biochemistry. I'm married to a pharmacist. I always bring that up because I think it's important to show that the advice that you're getting doesn't have to be alternative and natural or medication. It can be a combination of both. So I really pride myself on being kind of bias free when it comes to providing information to people. I'm a boy mom. I've got two little guys at home. So chaos life at home. And I am the CEO of Nutrichem. So we're kind of right down the road from the Memory Clinic on Carling. We're a compounding pharmacy and naturopathic clinic. We do personalize in prevention with a focus on women's health. And so I am going to be talking about some compounded options and nutrients. And this is all evidence informed, and it's not made by any financial incentives or anything behind the scenes. So when we talk about menopause, sometimes, we hear it as, okay, it's yay, it's the time my periods are done. Periods are over, and that's sometimes how it's presented, but it's so much more than that. What happens as a result of the loss of a period? Menopause is a neuroendocrine transition, and it impacts every single system in the body. And finally, there is so much more interest and empowerment in talking about what this means for women. So I'm going to spend quite a bit of time today, and there is a Q&A area, so you can pop some questions in there. I'm not sure where they'll pop up, but at the end I have some time for questions if you have any. So what does the menopause transition look like? So again, we're often told that menopause is when you have 12 months without a period. Okay, great, but it doesn't happen just black and white. It's extremely rare. We never see it where a woman has a very regular menstrual cycle like clockwork, and then all of a sudden it's done and it never comes back again. That's not how the transition works. There's this big, huge transitional time, and that's really where a lot of the symptoms and changes start. And really, that's what we're going to be talking about today, is how to understand where you are in that transitional time and different points in the transition present with different symptoms, and the treatment options that we offer, depending on what stage you're in, they also differ. So in that kind of early perimenopause or late reproductive stage, so that's kind of over here where you have kind of these regular ups and downs. You know, being women, it's never stable. There's even when things are regular, they're still changing. But what that means is you're having a very regular menstrual cycle. So 28 days. And obviously this doesn't apply to everyone because some people have conditions where they never really had a regular menstrual cycle. But for overall purposes, we're talking about in that late reproductive stage is when you have a regular menstrual cycle. The shifts into early perimenopause typically start early to mid 40s, or mid to late, so kind of sometime in the 40s range. It can start late 30s, it can start later in the 40s, but overall it is usually mid 40s, early to mid 40s. Really, what we're starting to see is changes in the period slightly. So anywhere between 1 and 7 days. So your period, you might have had a regular 28-day cycle, and now you're noticing it's 23 days, 25 days, 30 days. That's signaling that there's changes to the cycle, and your bleeding patterns might start to change. So it might start to get quite heavy, clotty, or a lot lighter. There might be more spotting. That's signaling that there's starting to be some changes going on in the brain ovarian connection, and that's kind of the first signs of early perimenopause. Now, symptomatically, that typically looks, what we typically see first is intensifying of PMS. So intensifying of the symptoms that lead up to the period. So intensifying of the mood swings, they might last longer. Sleep disruptions are a really big one that we see during this time. And we also can see a lot of heart palpitations, anxiety, that sort of thing come in when you have these really high swings, high and low. You see, there's no real rhyme or reason to this pattern here. It's up and down and up and down. And this is an oversimplification, but it is even more intense in those highs and lows. Late perimenopause, so as a woman shifts into late perimenopause, again, that is where you have more cycles being missed. So instead of the 7 days, you're now starting to miss a full period, and that's where you see these big lows in estrogen. And that is typically more when the hot flashes and night sweats start, low energy, that sort of thing can start to come in that late perimenopause. And early menopause is where you've not had a period for a year. So we're going to go through that again, but that's a very basic overview. So it is a transitional time. And I wanted to talk about what's actually happening in the body, because if we're going to talk about how the brain is impacted and how our cognition is impacted, I think it's really important that women understand, well, what's actually happening, so that we don't feel like it's all in our head. So it does start in the ovaries. So, you know, basic biology, from birth, women have a limited number of eggs in their ovaries, right? So like we'll call them the follicle. These follicles contains the eggs, and that's what's responsible for making the hormones like estrogen and progesterone. So as we age, of course, the finite number of eggs declines because every month we ovulate. So the number of eggs goes down. The remaining eggs or follicles also age with the rest of our body. And so the aging process in the ovary, in the follicles, impacts their responsiveness. So as we have aging eggs and declining number, they become less responsive to the signals coming from the brain telling them to grow and release hormones. And the brain must, as a result, because the brain wants to keep those hormone levels high, and it wants to keep cycles going, and it wants to keep ovulation up, it must send more and more signals to get that ovulation and hormone release to occur. So this is what it normally looks like. So the brain and the ovaries are working in a loop. Okay, so the brain is sending that signal, follicle stimulating hormone, luteinizing hormone, to the ovaries, and the ovaries are responding by producing estrogen and progesterone. Those high levels of estrogen and progesterone report back to the brain to say you can calm the signal down. Once it registers that the levels are low again, it'll start to send the signal, and that's what creates the menstrual cycle. During the menopause transition, this feedback loop becomes really unstable. So again, because of those things that we talked about, the declining number of eggs and the declining responsiveness, the brain must send stronger signals to try to get that ovarian response. And the ovaries can respond inconsistently, so they can release too much hormone or too little hormone. And that's where we get these big back and forth, huge swings because you can see it. Sometimes the brain has to send so much signal, it's stimulating one follicle to get ready to become ovulated while simultaneously stimulating a second one, right? And we can get these massive highs of estrogen compared to low progesterone. That can lead to changes in bleeding patterns, clottiness, heaviness, over thickening of the uterine lining. It can also create, if there's big drops or it's lower than normal, you can get the hot flashes, the mood swings, the sleep problems, brain fog, heart palpitations, anxiety. So these highs and lows that are very erratic and they're not cyclical and not smooth in nature can be very disruptive on how our brain navigates stability. And that's what's driving a lot of the symptoms that are coming up, especially in these perimenopausal years. So really with I've kind of circled it here, that early perimenopause into late is where a lot of the cognitive changes, or we get a lot of the reports of brain fog starting. And so this is where we have, the early perimenopause, the symptoms starting often as intensifying of PMS, little bits of change in the cycle, kind of plus or minus that 3 to 4 days, up to 7 days. Eventually, what will happen, again, your brain is trying to continue the ovulation, it's trying to keep those hormone levels high. Eventually, that will fail and ovulation won't occur, and you won't get the stimulation of hormone production by the ovaries. And that's again that transition into late perimenopause. And this is now where our brain and our body start to adjust to having lower levels of estrogen. So this often can look like, okay, all of a sudden I was having regular menstrual cycles and I just had a 45-day cycle or 60-day cycle. I just missed a period. And then you can go back to having a regular period for another 3 to 5 months, then maybe you skip 2 cycles. So that is the transition that you are now in late perimenopause, where your body is not able to maintain ovulation. And you really do switch from having those like massive high spikes and really lows to now getting quite low in estrogen. The brain and the bones and the cardiovascular system, they all must then adjust to the dropping estrogen levels. And then early menopause, like I said before, is when you no longer have a period and it's been 12 months, so we can be fairly confident that ovulation isn't going to occur again and you're not going to be producing estrogen or progesterone on your own anymore. And that's where a lot of the bigger changes come with prolonged not having any estrogen or progesterone, but estrogen is the key player here. To stimulate brain growth, to stimulate bone growth, to stimulate collagen, for cardiovascular protection. So that's where the body then starts to adjust to losing those estrogen levels. So today is all about cognition. So we're really going to hone in on the brain. Doesn't mean that there's not other areas that are impacted, but really, I really want to focus on brain health, because our brains love balance and they're always working behind the scenes to keep things steady and balanced. And of course, not just in our thoughts, but in how we feel. Our body works on a circadian rhythm, a clock, sleep, focus, and respond to the outside world. And of course, the brain and the body work together. The brain is getting signals and hormone, um, blood sugar, hormone level assessment, and then it's adjusting as needed. Okay, so it's deeply connected to other organs, especially the ones that produce hormones like the ovaries. So estrogen is really critical for brain functioning, and it impacts many areas of the brain, especially those involved in memory, mood, and focus. So again, as the levels drop, it can have really big impacts on the brain. And so we can start to see symptoms like brain fog, forgetfulness, trouble focusing, feeling more anxious, moody, or mentally drained. So there's kind of two factors when it comes to brain health, because 50% of women in menopause transition report subjective cognitive decline. And women with more intense menopause symptoms are much more likely to report these symptoms. So, yes, there is the impact of estrogen on the brain, on memory, on focus areas, but there's also the impact of changing hormone levels on things like sleep, right? So if you're not sleeping and you're having hot flashes at night or you're waking up with heart palpitations, not getting adequate sleep and getting into those restful recovery sleep stages will also have an impact on cognitive function and brain fog. So there's other areas, physiological areas that are impacted by the swings that themselves have impacts on our brain function. So what's normal during menopause? So I wanted to put this in because I always hear that. Is this normal? And it's very common. So many women experience temporary cognitive changes during the menopause transition. So just because you're having changes in brain fog, focus, concentration, memory doesn't mean there is something serious going on, and it is temporary typically. So the common symptoms include the memory, that focus, the recall, that executive functioning. So again, people are like, I can't pull numbers as fast as I did before. I'm not able to recall names. I'm not as sharp. Or I have lists everywhere I go, or else I forget. And I mean, we are tasked with remembering so many different things in our life. And the speed of life right now is kind of in hyperdrive. So there's other factors too, but obviously we're focusing on the hormonal implications today. These symptoms are often transient. So again, the brain is really trying to adapt. So once it has adapted, we often see return to normal functioning. But it doesn't mean that we don't support the symptoms and offer advice on how to best support brain health, cognitive function, and to prioritize prevention. So it's not a solution if a woman is working, has a high demanding job, taking care of her aging parents or her kids, navigating all the things going on and just saying, "Oh, yes, this is a normal part of the menopause transition. Hopefully it'll pass in 5 to 6 years. Good luck." That's not good enough, especially now we have more information about how we can support women through this. So just because it's transient doesn't mean we're not going to support it, and we're not going to talk about the brain and prevention. Specifically wanted to bring up Alzheimer's, of course, because we're talking about the memory clinic. So we do have the resources in Ottawa to get assessed, I think, which is good if you are concerned about the level of how this is actually impacting your quality of life. It is good to, we do have resources that you can use that are more experts in memory, cognition, things like Alzheimer's, and they're more equipped to be able to provide guidance than I would be. Hormones are my area, and memory and Alzheimer's is the memory clinic's focus. But Alzheimer's doesn't involve progressive or reversible cognitive decline. So through, neurodegeneration, changes in brain volume, plaque buildup, that sort of thing. But we do know that women are at a higher lifetime risk. And we do know that early or surgical menopause has shown to increase this risk. So when you want to pay closer attention is if it really significantly impacting your quality of life, persisting for 5 to 6 years post-menopause, if you have a family history of Alzheimer's dementia, if you've been tested and you carry the ApoE4 gene, or like I said, if it's really impacting your quality of life, then, that would be a good opportunity to chat with the memory clinic folks on that. And the purpose of this talk isn't to cause fear about Alzheimer's. It's really to bring the focus on how women's brain change during the menopause transition, because they do. And it's okay, and we need to talk about it so we can start to support it, right? Because we know that being a woman, our brain must adapt to pretty significant hormonal changes at a very set period in time. And we also know that women are living for 40% of their life in the postmenopausal years. So there's a big transitional time. There's the brain before and the brain after, and understanding the changes that can occur and how we support it through that change will help in prevention long term and supporting cognitive function later on in life. So again, it's a neurological transition, and temporary brain changes can show up, so it is good for us to talk about it. So how are we going to support your brain and your body? So I didn't just put supporting your brain, because we can't support the brain without supporting the body, and we can't support the body without supporting the brain, right? We're all one unit. So the whole body, physically, mentally, nutritionally, hormonally, that's creating the best foundation for lasting brain health. And of course, supporting clarity during this menopause transition. So some of the things we'll talk about are still very classic, but it's because it is so foundational, right? There's no quick fixes to brain health. There is no hacks. It really is about, first of all, identifying where you are in the transition, understanding what is going on, what is driving your symptoms. So, firstly, to validate that they are real and it's not something you're making up in your head, because I hear that all the time. And then building a plan to support and uncover what's actually going on that could be making the symptoms rise. And then how do we support you? So have to start with physical activity. Again, for any condition out there, really, movement is so, so key. So it is improving blood flow to the brain, supports mood and memory, reduces brain fog, anxiety, sleep disturbances. And it is strongly linked to a lower risk of cognitive decline, including Alzheimer's. So we want to aim for 30 minutes most days. So walking, yoga, strength training. I think the key here is just movement. It doesn't have to be perfect. It doesn't have to be the best type for cognition. At the end of the day, just having consistency and moving your body is really, really important. And I think sometimes we try to do things so perfectly that we get overwhelmed and then we kind of give up. So even in the summer, walking and being present in nature, like these things are actually have research behind them that they are really helpful for supporting mood and memory, especially in perimenopause and menopause, and really anytime. More physical movement and activity can help with sleep, and sleep helps with recovery and restoration. So whatever we're doing to help support our body recovering will always be really, really key. So I always talk about kind of physical activity and movement, especially when there is a mood memory piece. So I get the question a lot, well, what's the perfect diet for brain fog, or what's the perfect diet for Alzheimer's prevention? And, there's not one perfect diet out there, but the one with the best research that's most consistently shown benefit is kind of that Mediterranean style diet. So it's balanced, it's based on whole foods, whole grains, lean protein, and really when the brain part of this is the healthy fat component. So the brain is made up of fats, and we want to make sure that the fats that we're giving our brain are really healthy, omega-3, omega-6, 9 rich. So nuts, olive oils, the fatty fish, these are very anti-inflammatory, help support building those cellular membranes. So really keeping it balanced, whole food base is key. We don't need to go extreme with a keto diet or going crazy on fats and trying to add more and more fat into our diet. Really, if you're keeping it balanced, that is key. That's really, really key. And not only is eating for brain power about what we are eating, but it's also about what we're not eating. And so in having a diet that's more full of whole grains, full of fiber, vegetables, whole foods that aren't processed, you will inherently limit your refined sugar and carbs. So, not having a lot of refinement in your sugars is really important. So, you're not having these high sugar spikes and lows. So, having a diet that has the grains, legumes, healthy fats, and protein can really help balance out your appetite control, and it can actually really help with not having those high fluctuations of blood sugar. And that's a really big issue when it comes to mood and mental clarity, right? If you have a lot of highs and lows in blood sugar, if you're eating, and I'm sure everybody here has done it. Someone in the office, you bring, there's donuts, there's a treat, there's a birthday, you eat it, and then after lunch, your brain is just, you need a nap, you feel brain dead, the fog is really coming on. So that type of energy for the brain where it's really, really, really fast, quick, super, it'll raise your sugars really high and then it'll bottom them out really low. That's not a good sustainable diet for brain fog, mood balancing. So we really want to have whole foods that will release sugars really nice and slowly over time. They'll help balance out your insulin response so it's not going to be so high and low. So there's a lot of benefit in eating this way, kind of behind the scenes, but that does help balance out those blood sugar highs and lows. The next one to limit is alcohol. So we can't do a talk on menopause and the menopause transition without chatting about alcohol. The impacts on sleep, the impacts on mood, the impacts on brain fog are quite significant. So really paying attention to how much alcohol you're consuming, how your sleep is doing. It's a really big trigger for hot flashes and night sweats as well. And also, once you see where you are in that transitional time, if you're right in the middle or kind of in the late stage or about to enter the early stage, our bodies are functioning differently. Like our brains and our ovaries are trying to navigate a lot of changes that are rooted in some biology as well. Adding in more factors that can throw in imbalance can put more pressure on the system. So anything we can do to kind of eliminate more pressure and keep things more smooth and balanced, like eating kind of a high balance diet with protein, reducing alcohol, can have a really, really significant impact. And our ability to process these things, our ability to process alcohol, our ability to process sugar changes with age. And so just because you're able to tolerate it at one time doesn't mean your body is able to keep doing it the same way. So that's my rant uh, about diet. It doesn't mean that you can't eat processed foods at all, though. I'm really not black and white. I think that, the majority of the time maintaining a whole foods diet, but not beating yourself up if you go out or if you have a treat. It's more kind of keeping within what is your norm? What are you doing most of the time? And then having the ability to be flexible because we're not going to be perfect and we don't want to have that guilt, shame that's going to make us actually give up on the whole thing in the first place. Blood pressure management is something we don't talk often about when we talk about cognitive health, but it has a lot of research behind it, and it actually is quite critical. It's also one of those pieces to the puzzle, just like blood sugar, right? We have pretty key foundational pieces in how our body is adjusting, right? We have blood sugar regulation, that is like glucose is how our brains get energy. And then there's the pressure of the system. How much pressure is our system under? And in the perimenopausal menopause transitional time, depending on where you are, this is often when we can start to see high blood pressure start. So again, if your arteries are already starting to adjust to the loss of estrogen, they can become more rigid. You can have more plaque buildup. This is when we can have that tipping point where your numbers start to actually climb. So we can start to see in hypertension, having high blood pressure can negatively affect brain function, circulation, and it can have implications in memory and cognition. So absolutely, there's quite clear links between blood pressure and brain function. It's not something that you'll feel immediately. So unless you have crazy high blood pressure where it's an emergency, blood pressure, talking about your blood pressure and managing blood pressure is something that we would do today for 20 years from now, because it's that increased pressure on the system that can damage the eyes, the kidneys, the brain, areas that are very sensitive to even slight changes in pressure. So managing that is a key step. On the other side, if you were a woman, and again, I see this a lot of the time as well, who tends to have very, very low blood pressure, and now you're entering early perimenopause, or you're kind of in that between early and late, and you're having more frequent periods, they're really heavy, you're losing a lot of blood, you might be someone that's actually dropping really low in your blood pressure and you're finding yourself getting really dizzy frequently, or you find yourself kind of foggy, low energy, and especially if you're working out a lot, that's when we really need to understand where your blood pressure is at. So the kind of first piece of advice I have here is actually just to check your blood pressure fairly regularly, especially during this transitional time. So maybe once or twice a week, just to kind of get used to your numbers. If your numbers are fine, you don't need to do it as frequently, but it can really arm you with a lot of tools because we know that things can be changing during this time. If you're someone who, I always tell people, I'm like, just take a picture of the screen and have a folder that you just kind of add your pictures to, or a notebook or on your notes. That way, if for some reason you're at your doctor's office, they decide to do your blood pressure, and on that day you had a coffee, you rushed to get in, your blood pressure's through the roof, you can now be like, this is not normal for me. Like, normally I sit here, that's really abnormal for my numbers. Otherwise, again, you can start to get kind of funneled down a system or funneled down a path that may or may not be relevant. So you doing it home in a more calm environment can really help give you a lot more data as to where you need to support yourself. Being aware of sodium consumption. So if you're someone who eats more processed foods, really high in sodium. If you're someone who eats a fairly very like a Mediterranean diet, very low in sodium. So those ones you'll want to salt your food and make sure you're getting enough sodium. So understanding where your pressure at can actually help dictate whether or not you should use electrolytes, how much you should salt your food. You might need magnesium. And of course, if you've been prescribed a blood pressure medication, you want to make sure that you're actually taking it or that it's working for your blood pressure. So now we're going to talk about, so those are kind of key foundational pieces, is move your body, eating a whole foods diet, and thinking about blood sugar regulation and blood pressure regulation. Now we're going to go into the kind of the core nutrients that have been studied around brain health. So the number one most researched out there is omega-3s. So from fish or flax oil. Again, our brain is made up of fatty tissue with fatty phospholipids around the cell membrane. So we really want to support that brain cell structure. And so again, omega-3s are definitely the most researched supplement for cognitive health, like also for cardiovascular health, but also for prevention of Alzheimer's disease. I think it's really important when we're talking about nutrients to understand what to expect. So with fish oils, if you take one small little capsule of fish oil, there's a big variation of doses and quality. So you might be getting 120 milligrams of EPA, 100 of DHA. You might not be getting enough to ever feel anything. So if we're actually trying to support cognitive function, brain health, skin health, eye health, we really want to be getting into the gram doses. Again, you do want to talk to your healthcare providers on this, but oftentimes you do need to go a little bit higher dosing to actually feel the differences with fish oil, and you do have to take it for a while consistently. It's not something you're going to feel the next day by taking a fish oil. B vitamins. So when we're talking about brain health, memory, focus, cognition, energy, pieces that come up often in these menopausal transitional years, there is kind of a process called methylation that requires movement of this group of methyls through B12 and folate, which is what helps with our brain signaling. So we want to make sure that we are addressing that and we're bringing some of these markers down to support cognitive function. If your B12 levels are low, B12 is critical for making the myelin, which is the coating around our nerves. So again, making sure that you're getting your B12 levels checked, and do you need to supplement with it? Are you absorbing it through your gut? Why or why not? Because this might be implicated in why you're feeling certain symptoms. Then we have vitamin D and magnesium. So vitamin D, we're all deficient in Canada. We don't get hardly any sun, especially this winter and spring. Critical for mood support, cognition, but again, through the menopausal, right? We never think about things with blinders on, right? So when we're talking about cognition, in the changes in the transitional time in menopause, we also know that bone structure is changing. We also know that the cardiovascular system is changing. So all of the things that we're recommending, so fish oil, B vitamins, vitamin D, magnesium, these are all very relevant for all of the changes that happen because we know that the less severe the other menopausal symptoms are, the better the outcomes for cognition as well. So getting your vitamin D levels checked is really important before, especially if we're going to dose a little bit higher, we need to know where you're at. Magnesium, again, really, really critical for a lot of the other symptoms that can come along with menopause. So really good for sleep, muscle tension, those hot flashes and night sweats. So many of the symptoms that are associated with more severe cognitive impairment is where we really want to kind of bring some magnesium in. So these are the most well-studied, well-rounded, very safe, very well-tolerated supplements. Of course, there's other kind of what we call nootropics out there. There's the antioxidants, there's the NAD, NMN, resveratrol, all these other products out there. Those ones are a little bit more new and the research is more emerging. These ones are really kind of core foundational that we can't get to those ones unless we've done the movement, the diet, and all these critical pieces. And then we're going to talk, and then the big other piece is hormones. Okay, so menopause hormone therapy. So, you might notice so there's differences in the terminology now. We used to call it hormone replacement therapy. We can still call it hormone replacement therapy. More and more associations are moving and research is moving into using the term menopause hormone therapy because we're able to give hormones before a woman has completely lost all of her hormones. So you're going to see MHT. That's referring to bringing in estrogen and progesterone during these transitional years. Critical window. So there is a critical window. The theme of a critical window is really, really big for hormones when we're talking about hormones. So yes, it's important for the brain, but it's also important for when we're bringing in hormones in general. So the critical window when it comes to brain health and cognitive function is that it's really it's shown to be much more effective when it started in the earlier menopause transition before the brain has adjusted to the loss of estrogen. And this is this is kind of consistent across the board when it comes to bone health. So bringing in hormones before the bones have adjusted to the loss of estrogen can show that it can prevent more risk of breaks. Same with cardiovascular disease. Bringing it in earlier before the plaques and the arteries have kind of built up and become more rigid, better outcomes as well. So in select groups, so a lot of the groups that they've done the most research with on hormones is the surgical menopause group. So people that have had a full hysterectomy or a chemical menopause if you've had to have some sort of a like radiation or something to the area, or early menopause or premature ovarian insufficiency. That's where you really see the best outcomes in verbal memory and cognitive function when using hormone therapy. If you're bringing it in later, so 10 years post last menstrual period, that's where the benefits really become a little bit more murky. There's potential harm. Like there's a lot of inconsistencies in the research in terms of cognitive function. So earlier, better. Transdermal estradiol and micronized progesterone are the forms that are preferred for brain health. And again, I spoke on this before, more women are living 40% of their life post-menopause. Like we have years and years. So the things that we do during the transitional time, because sometimes we hear, oh, menopause is natural. Why should we don't need to change anything that we're doing. It's not about preventing menopause, right? It's going to happen. It's about supporting our brain, our body, our bones, our cardiovascular system so that as we age into the postmenopausal years, we can be more independent, we can move better, we can think better. This is kind of critical for that preventative medicine piece. So it's not anti-aging, it's actually just more empowering and understanding how hormones impact your body and how we can get better outcomes later on in life. So it's not hormone therapy is not indicated for dementia prevention, or Alzheimer's prevention is a sole indication. So, if someone comes in and they say, "Oh, my mom has Alzheimer's, I'm worried about that," we couldn't just initiate hormones just with that alone. And again, surgical menopause, really, it's critical to mitigate the cognitive decline. So someone's coming in with a full hysterectomy or early menopause or premature ovarian insufficiency, we have to start hormones quite high right away for the cardiovascular and brain health piece. So let's talk about what those actually look like, because again, I think there is a lot of misinformation, and that's what I hear. The terms bioidentical hormones get tossed around a lot. People aren't really sure what that means. So there's bioidentical estrogen, that's 17-beta estradiol. So we're going to call it estradiol. It's the same estrogen that your ovaries are releasing. There's three forms of main estrogen, but this is the main one our ovaries release. It's the most bioactive in our body. This is the hormone that's available in compounded creams. That's kind of a lot of what we do here at Nutrichem. There's also a lot of commercially available gels, patches in varying doses, and those are also bioidentical. Those are also estradiol. It's the same. So those can be prescribed by your naturopathic doctor, your MD, your OB-GYN, or your nurse practitioner. So you don't have to get bioidentical from a naturopathic doctor. I think there's a bit of a misconception there. There's a lot of commercially available estrogens, estradiol, that is bioidentical as well. So I just want to make sure that I said that in this presentation. And you can start hormones during perimenopause. You don't have to wait until your period's been done for a year to use estrogen and hormones. And again, that's a shift in kind of mindset in people that are doing more of the research, is that it's actually better to start a little bit earlier, because that's often when the symptoms are the worst and when we need it the most. So why are we waiting after to start to give a woman a therapeutic of the hormone that her body has been naturally producing for her whole life? Let's not make people afraid of their own hormones. And there is nuance, and hormones are not appropriate for everyone, and we're going to talk about this. But it is important to open up the conversation. So the dose should and can be tailored to accommodate the fluxes, and they must be adjusted as needed depending on the response. So with estradiol, especially if we're starting it in perimenopause, we want to start very low and very slow, because your body is still having a menstrual cycle. So you're still going to have some ups and downs. It's very typically, if we think back to that graph of when there was like the regular cycles and the crazy highs and lows, and then we started to see the bigger lower dips, estradiol is really kind of key in that late perimenopausal stage where we started to skip periods. That's where this is appropriate to start bringing it in. Not when someone's having crazy heavy menstrual periods, bleeding all over the place, they're frequent, not the best time to bring it in. Really when we've had that transition into late. Like I said, hormones are not for everybody, and every woman should understand her choices, and always the choice is yours. You get to be presented the information, the evidence, the risks, and you get to decide. And it should be based on information and not fear or bias. So hormones aren't appropriate if it's been 10 years since you've had your last menstrual period. There's nuance to this. So again, there's always nuance and gray zones, but in general, if you have uncontrolled blood pressure, if you have uncontrolled cholesterol levels, if you have a personal history of breast cancer or endometrial cancer, if you have a family history of breast cancer, it does not mean hormones are contraindicated for you, but it means that we should understand your risk. Was it a direct relative? Was it a mom or a sister? And when were they diagnosed? If it's an aunt, a grandma, that sort of thing, again, it changes the conversation, but these are conversations you must have with your provider. If you've had a stroke, a clot, or a cardiovascular event, again, not appropriate for you. Surgical and early menopause. So if you're finding that you're missing your period and you're starting to transition into menopause and you're in your mid 40s, early 40s, then getting hormones in and moving the dose up a little higher a bit sooner is quite important for bone, cardiovascular, and brain health. And again, that's pretty consistent through the research. And again, the best results when specifically talking to Alzheimer's risk reduction is in women with that ApoE4 gene. So again, if you're someone that has a strong family history, you've had your genetics done, that's where a lot of the best results are for using hormone therapy. And we can't talk about estrogen without talking about progesterone. So we can't, so micronized progesterone, this is the best option for brain health. So there's progestins. These are the synthetic progestins. It's not bioidentical. This is what you would have in an IUD or what would be in birth control or the Depo-Provera shot. These are synthetics. So it's not the same as what your body makes. And it can be initiated as well in these perimenopausal years. The difference with progesterone is that we can use progesterone on its own. We don't need to bring in an estrogen. With estrogen, we must have a progesterone if you have a uterus. So if you've had a partial hysterectomy, we can use estradiol on its own, but if you still have that uterus, we have to bring in progesterone and it must be at a minimum adequate dose. So usually around 100 milligrams. Yes, that's basic. But if during that high and low early perimenopausal time, this is where progesterone can be extremely beneficial for women. So when you have those highs and lows, the changing bleeding patterns, the anxiety, palpitations, sleep issues, progesterone can be an amazingly beneficial way to help with sleep, mood, anxiety, and it can be compounded. It can be made into a cream, a capsule, low dosing. We don't need to get you up to a dose. It's really for symptom management. Oftentimes, as a naturopath, we use progesterone and we use some different botanicals and herbs to get you through to that several years until we get to that late perimenopause, and that might be when we now need to bring in estrogen if the hot flashes are kind of starting up more, or the brain fog is getting more severe, or the energy drops are kind of coming in. That's where we can start to tell where the estrogen is really dropping. So the take-home message is progress over perfection, right? We're not here to be perfect. We're just here to be consistent and learn more and understand and validate what we're going through. Moving your body, feed your brain with healthy, whole foods, bring in a meditation practice, supporting all these things will support your sleep. If you've never had your vitamin D or B12 checked or your cholesterol, like look at those things if you're in this transitional time. And if needed, you can talk to your doctor, talk to your healthcare provider on how to initiate hormone therapy low and slow and earlier if appropriate. Again, specifically more, for the other symptoms before the brain, bones, cardiovascular system have adjusted to the loss of estrogen. So I know that was a lot of information and we only had a short period of time today. So I wanted to give a very brief, like a broad overview of where kind of the biggest pieces of research is. I know there's so much information out there on hormones and estrogen. So I thought it was really important to talk about it. Sometimes it used to be no one wanted to talk about estrogen, and now estrogen is being touted as like the cure-all for everything. So there is a stage and a time and a dose that's more appropriate. It isn't appropriate for everyone, but for those who it's appropriate for, it can work really, really well. But you want to make sure you're working with someone who knows what they're doing, knows how to dose it, knows how to screen you properly, and knows how to kind of walk you through the stages. So if anyone has questions, we do have a little bit of time. That's the clinic email for Nutrichem, and the phone number. We've got a team of NDs who specialize in supporting women through the menopause transition. That's our website. And my Instagram, if anyone's interested or has any more questions. So let me see here. Oh, can you identify which practitioners can prescribe what? I'm always confused as to who I have to talk to about which prescriptions. Tend to ask my naturopath, but no. Oh, that's a great question. So that's really important. So naturopathic doctors, if you've written the prescribing exam, so not every naturopath can prescribe hormones, but naturopathic doctors can prescribe estrogen and they can prescribe topical progesterone. But your MD can also prescribe hormones as well. So can a gynecologist, so can a nurse practitioner. If you go to a OB-GYN or a medical doctor or a nurse practitioner, you will very likely be getting the commercially available either an estrogel and a micronized progesterone at 100 milligrams. That is totally fine. Those are both bioidentical. It's really usually about having more of the questions answered about, well, when should I start or stop? So, but all those practitioners can do it, and I encourage getting different opinions from different practitioners. What can you take if you're allergic to fish, seashell, and seafood? So none of these have fish, seashell, seafood in terms of hormones. If we're talking about a fish oil, then you can use a flax oil to get your omega-3s. Does the brain fog ever go away? I feel like I'm reverting back to my childhood. I can't remember the basics. Yeah, so it again, we always have to build up on understanding what is driving the brain fog. So I do think it's really important that for women, we don't just assume, oh, it's menopause. That's what's causing all your symptoms. So just because we know that hormones are a factor, especially if you're between the ages of 40 and, 57, 60, but we should also be understanding, well, what's going on with your blood pressure? Is there a sleep apnea? What's happening with your B12 levels? Do you have adequate vitamin D? What's happening with iron? Um, there's other pieces to the puzzle that we must also address so that we can help support kind of clearing that brain fog and getting the optimal cognitive function. And if not, then we should get more assessments as well. So that's again why I love chatting with the memory clinic, because they're doing a lot of the other work as well. I saw another question. Oh, here we go. What are optimal levels of estrogen and progesterone? Oh, this is a good question. Do you measure it with blood tests? So blood tests are, again, there's nuance with blood tests. We don't, so blood tests can be helpful. Oh, okay, so actually I forgot to mention this when I was doing the high and low chart that you saw. There's some circumstances where it's very difficult for a woman to understand what stage she's in. So if you've had a partial hysterectomy, so if you don't have a uterus, or if you have an IUD, right? There's no bleeding, so we don't know if the bleeding is changing. We don't know if you're in late perimenopause, if you're in full-on menopause, are you in early? So blood testing at this point can actually be really helpful to see, are we going to catch a really low estrogen and a high FSH? We don't need to do blood testing because your levels are so all over the place. It's very difficult to use a blood test to determine a stage unless someone, again, like I said, doesn't have a bleeding pattern. If you're in late perimenopause or even early, I often do blood tests with testing hormone levels just to see if the body is farther along than I'm assuming. So if I catch a high FSH and a really low estrogen, then I know that your body is dipping really low. Just because I didn't catch it doesn't mean it's not happening, but it's less likely. So as a woman transitions into postmenopause and there's no period anymore, we can use blood levels to kind of see, can we go any higher with the dose? But with hormones, it's not about achieving a specific blood level. It's really about supporting symptoms. So the key foundation here is treating the woman, and not trying to get to a certain serum level. And we know, like, there's maybe with bones when it's very severe risk of osteoporosis, that's really the only case of needing to go a little bit higher. If we test, because I do always test, I still do, 6 months after initiating in menopause, just to make sure, are you absorbing it? Can we go higher? Are you a max absorber? If a woman went through menopause early, so again, if you're losing your period and you're in your 40s, early mid 40s, we're going to go right to a higher dose for better protection of bones. And again, that would be a case where we want to make sure you're absorbing adequately. And if not, we can kind of start to taper you up a little bit and taper up that progesterone as well. What herbs do you commonly use with success in menopause and combination? So again, these are really, really good questions. Herbs, I love herbs. I'm a naturopathic doctor. We need to understand what we're using them for. So if we're using herbal medicine, so if we're using something like Vitex or Chase Tree, same thing, have some of the best research for managing PMS, mood swings, that sort of thing. We would bring that in the early perimenopausal stage. So Vitex, there's nutrients like calcium D-glucarate or DIM or I3C. These are things that'll help metabolize estrogen. Would those help in actually driving more blood flow to the brain, mitigating the loss of brain volume and that sort of thing? No, they won't replace what estrogen does, but for symptom management, they're a really useful tool when things are very erratic to start to help support. So those are kind of what we typically use in those years. Can you please talk a little bit more about how menopause hormone therapy is most helpful for women with the ApoE4 gene? Does that mean that menopause increases the risk of developing or that the cognitive changes are worse from them? No, it's more that the response to hormone therapy, specifically for mitigating cognitive changes, seems to be much more pronounced in women with the ApoE4 gene. So I hope that answers the question. Testosterone replacement therapy. Okay, so naturopathic doctors, we cannot prescribe testosterone currently. I don't use testosterone in my practice. There are specific cases. So testosterone can be made from the adrenal glands. You can still make it post-menopause. Um, do we need it? Women need testosterone. Do we have to bring it in? Rarely do I have a case where we haven't had enough benefit with estrogen and progesterone that we must use testosterone. If a woman is an athlete or losing a lot of muscle mass or there's significant issues with libido, those are the unique cases where we bring in testosterone. Oh, when should one stop menopause hormone therapy or hormones post menopause? Great question. So used to be that it was kind of that 10-year rule, 5 to 10 years, or at age 60, like we're done. Now, again, the North American Menopause Society, all the menopause societies in 2023 put out new guidelines that as long as you're being evaluated and you have a practitioner who is reassessing risk, there is no line in the sand in which you must stop hormone therapy. So the window of opportunity is really much more critical about when to start than it is when to stop. So once you've started, as long as you're continuing to be evaluated, there's still a benefit, you're still getting screening done, we're still assessing your lipid levels, and we can continue to give you hormone therapy. And there isn't a specific cutoff time that we have to stop. Initiating it later is a different story. That one actually carries more risk than it is to continue on a little bit longer. Are there any supplements you recommend short term to help address brain fog while working to address the root cause? So again, really working more on like the diet stuff is so critical for brain fog. So using things like making sure you're aware of your sugar, your alcohol, that sort of thing. Really, if we're looking for brain fog support, depending on where it is, we might bring in B12, we might bring those high doses of fish oil. There are some other compounds like phosphatidylserine, like those kind of nootropics. Creatine is actually a really big one for energy and brain health now. So these are things that can be brought in. The effects of them, if we're not doing the other pieces, tends to not be as pronounced. I have time for one more question, so I'll just read this last one here. What about vaginal estrogen? How much is absorbed? Oh, such good questions, ladies. I love it. So vaginal estrogen is its own story. Vaginal estrogen doesn't count as hormone replacement therapy, menopause replacement therapy. Vaginal estrogen is local estrogen therapy. So it doesn't need to be paired with a progesterone. It's very localized for the genitourinary changes of menopause. So changes in vaginal dryness, changes in frequency, like frequency, urgency, painful intercourse, discomfort, that sort of thing. That's when we would bring in a vaginal estrogen, change in sexual health. So it's really not absorbed systemically. I tend to use it more in a cream, so it can be applied externally and internally. There's tablet forms, Vagifem. There's lower dose tablets now, Imvexi, and then there's vaginal creams that we use. So again, systemic absorption is minimal. You can go lower if we're worried about absorption, or because every woman is different. Some women, even though we say it's not absorbed systemically, some women are extremely sensitive. And if you haven't had estrogen in years, putting a little bit vaginally, you can't. Sometimes I've had patients, a very odd patient, say I've gotten symptoms from a vaginal estrogen. We would just go a lot lower on that dose. Okay, I think we answered all the questions. So thank you everyone for spending your lunch hour with me. That was great. And if you have any other questions, like I said, you can always direct them to the clinic. We do have a lot of really great naturopathic doctors who are just as passionate as I am about women's health and hormones. So have a lovely day. And if there's anything you forgot about, you can also follow me on Instagram and comment on my post with your questions and I'll answer it. Bye, everybody.